Good evening. My name is Pat Bensettler, and I'm the chair of the Bolton Human Services and Safety Committee. And tonight we're doing a forum on concussions. The person who has really helped us organize is a member of our committee, Laura Roberts. And I'm going to be handing this over to Laura. I do want to give a big shout out to Chris and Fred, our other two members. And if anybody after you see this tonight wants to be a member of our committee, please contact Linda Day. Thank you.
Thanks, Pat. So I'm Laura Roberts, a member of the committee, and I reached out to the Cantu Concussion Center at Emerson Hospital, and these lovely ladies are here to talk to us about concussions. So I won't say much more because I don't know that much about concussions, and you guys can all learn from them, and feel free to ask, I'm sure, lots of questions and get them answered. All right? Thank you.
I have an additional request. If everyone would fill out their surveys, that would be a huge help. Because it not only answers questions about this event, but what you would like to see in the future.
So thank you very much for coming.
You're welcome. So my name's Ellen. This is Kristen and Caitlin. We're all nurse practitioners at the Robert Cantu Concussion Center through Emerson Hospital in Concord. Let's see. All right, so let's start off with what a concussion is. It is considered a mild traumatic brain injury that's caused by a force or jolt to the head that causes a shaking of the brain within the skull. This was a video showing that, but we can't seem to get that to work. A concussion can also occur without any contact to the head. Somebody's body could get hit. That causes the head to rapidly change speed or direction. This would be a whiplash injury. It's common in sports as well as motor vehicle accidents. So there's two types of forces that are involved with sustaining a concussion. Usually it's a combination of the two. But the first one is a linear force, so that's the forward and backwards motion of the acceleration and deceleration. And this would be like getting rear-ended, a car smashing into a tree, and that would be a stretching injury to the brain. The rotational force is an off-center hit to the head that causes the brain to rotate or spin within the skull. Usually this is more damaging than a linear force. And that would cause stretching, shearing, tearing of blood vessels in the brain. And an example of this would be a football player is running forward and gets tackled unexpectedly from the side. Like I said, usually it's a combination of both for head injuries. So immediately following the injury, the brain goes into an overactive state, releasing chemicals called neurotransmitters that are normally used when brain cells communicate with each other. But after an injury, they all are being released at the same time by all the cells. The system becomes very overloaded. There's no regulation to it. So in order to correct this imbalance, the brain needs energy to do so. And also following an injury, the brain's ability to metabolize energy becomes impaired. So this can take days, weeks, or even months to kind of fix the imbalance of the chemicals or the neurotransmitters. And the chemical changes also make the brain more sensitive to any further stress on the brain, which is what causes the symptoms. So this is what to look for if you have seen somebody get a hit to the head and you're wondering if they have a concussion. So they often appear dazed or confused, have a hard time getting up, they're unsteady or stumbling. You want to ask them if they remember what happened before the hit, what hit them, and if they remember the moments after. Sometimes that you can lose consciousness, vomiting, or nausea can occur. So any signs of this, if it's an athletic situation, you definitely want to pull them from the sport or game. And symptoms can also be delayed, so that's another reason why to kind of stop what you're doing and put yourself in a safe place to not sustain any future injuries. So these are red flag symptoms, when to call 911 or go to the ER after a head injury. So this would mean, or you'd want to do so if the headache was getting worse, if it was becoming the worst headache you've ever had, any weakness, poor coordination, kind of vomiting that's not stopping. Obviously, any seizures, you want to call 911. Trouble speaking, you definitely want to ask the patient or the person questions to see what their speech sounds like. Again, you want to see if they're oriented, so you want to ask their name, where they are, what the date is, and again, just information about what happened. You want to look at their pupils to see if the pupils are unequal in size, and then if there's any discharge from ears or nose, especially clear, that would be definitely a sign to call 911. So like I said, symptoms can be delayed, so it's really important to continue monitoring these, not just immediately after the injury. These symptoms can indicate a brain bleed or a more serious head injury than a concussion, and it would be really important to get evaluated as soon as possible, as that can progress very quickly. So these are the concussion symptoms that usually patients feel either immediately following the injury or throughout the recovery. We have them divided into 4 separate domains, so cognitive symptoms, somatic or physical symptoms, emotional symptoms, and then sleep disturbances. Every time we see patients in our office, we have a list of these symptoms and ask them to rate it on a scale of 0 to 6 every time they come in, so you can kind of see them recover or their progression. And Kristen's going to talk more about that later. But this is just a list of the most common, but it really varies from patient to patient as far as which symptoms will be most dominant.
One of the things that we've tried to focus on is to teach people who are living alone, who are for the most part elderly, how they make decisions in situations like this. Let's say they've fallen down the stairs. That might be enough for them to call 911. But what other symptoms would you suggest that we emphasize to an elderly person who is fallen? Because that's one of our most common calls.
So certainly if there's bleeding, if there's some sort of laceration, if they have if they're feeling dizzy, off balance, if they felt like they blacked out after the injury, then I would call 911. If there's visual changes, any kind of blind spots, flashing lights, blurred vision, double vision, anything like that. Do you guys have any other?
I would say that's
If they're alone, I mean, that's
call 911.
Yeah.
If they were having a headache, lighter noise sensitivity, felt a little dazed and off, it would probably be appropriate to call their primary care provider.
Yeah.
Maybe you don't have to go right to the emergency room if they're not having any bleeding, or if they don't think they lost consciousness, or if they don't feel they don't have any symptoms that are very alarming to them. The red flags that we talked about, the leaking of some fluid maybe from the ear to the nose. But if they just felt off, usually that's an indication that you can call your primary care provider and maybe be seen there instead of the emergency room.
Yeah. Or even a friend or a family member to just come stay with them for the day, just to see how they're acting, their speech, if they're forgetting things or anything like that.
One of the rules, if you will, this is a small town, to call 911 because we have a really good EMS crew, and if you need to go to the hospital, they can take you, but they don't have to.
Okay, so they come and do an assessment and then determine.
Right.
Yeah, that's great. That's really good to have. Yeah. So in that case, I would recommend if they fall and they're having any sort of symptoms, I would call 911 then. Yeah. It's just to be evaluated by somebody.
Good question.
Is there something, other conditions that have the same collection of symptoms?
There are a lot, actually.
It is big. I mean, usually it's correlated to an injury, though, after an injury.
Well, this is, because it really all was talking about trauma. So.
Yeah. So some sort of hit to the head, and then developing these symptoms afterwards.
And the reason to get treatment is it gets worse.
Yeah, and initially you want to be evaluated to see if there's any emergency situations that would need imaging, anything like that. And yeah, it would be good to be seen initially, just in case you don't get better. The provider would have the initial kind of snapshot of what your symptoms are like at the
Part of
beginning.
this collection of symptoms is immediate, and some of it is like people think, well, sleeping more than usual is not something we're going to necessarily connect with the fall until the next day.
Yeah, it can be a delay a couple of days. Yeah.
Was a couple of days delay a problem?
What do you mean?
And is a couple of days delay in seeking treatment make matters worse?
It can prolong the recovery a little bit, but I don't think you're doing more damage to the brain.
Yeah.
Just prolongs the recovery a little bit.
I mean, if you're resting in those days but still continue to develop symptoms, it's nothing that you're doing. It's just kind of the progression of what the injury is.
Oftentimes people will develop symptoms a few days after, 24 to 48 hours after, because initially they're resting. They're not doing much physically, cognitively at rest, but then they start to return to their daily activities, and that's when they can start provoking symptoms.
So that kind of leads into my next my next point is after you have sustained a concussion, now what do you do? I do want to emphasize, as long as you're not having those red flag symptoms that I talked about, then the first recommended therapy would be to rest your brain. So that would be both physical rest and cognitive rest. So physical rest includes no sports, weight training, cardio. You don't want to be doing any activities that increase your heart rate or your blood pressure. And then cognitive rest, you want to limit the screens, which I'm sure you've all heard of. But that includes computers, smartphones, iPads, Kindles, TV, video games, which is usually more difficult for our younger population. And then you want to reduce activities that require a lot of thinking, complex decision making. If this is a younger patient, you want to limit their schoolwork, limit exams initially. In the adult population, we want to reduce their workload, reduce work hours, probably take some days off work immediately following. And then you want to avoid places that are busy, noisy, bright lights, crowds, things like that. And then you want to reduce the potential for a second head injury while you're still recovering from the initial one. So that would be refraining from all high-risk activities such as contact sports, skateboarding, bike riding, skiing, snowboarding, patients with high-risk jobs like construction workers who go up on ladders, EMTs, police officers, things like that. We pull them from work until they're pretty much almost back to their baseline, just so they don't have that chance of sustaining a second injury. So second impact syndrome is very rare, but it can happen if an individual sustains a second injury while the brain is not fully healed from the initial injury. So in a normal brain, you are constantly maintaining normal blood flow, normal brain pressure through something called autoregulation. And when you get hit a second time, this can disrupt that autoregulation and cause a massive inflow of blood and pressure into the brain, which can be quite serious, can cause death, if not death, and usually severely disabled. Like I said, this is extremely rare. In one study that Dr. Cantu, who opened this clinic, a study he was involved with, over a 13-year interval, there was 94 instances of second impact syndrome, which resulted in death or permanently disabled. Unfortunately, almost all of the patients were high school players, and 3/4 of them had a previous concussion that same season, and then 40% were on the field despite having concussion symptoms. So extremely rare, but also preventable. So a normal concussion recovery, 70 to 90% of adults will recover in about 7 to 10 days. Usually is self-limiting, but there is, you can have a prolonged recovery, which would be longer than 1 month. Some things that put you at risk for having a longer recovery would be younger in age, so our pediatric population, being female, having a loss of consciousness at the time of the injury, post-traumatic amnesia, which is forgetting the moments right before the injury or right after, a previous history of concussions, any pre-existing learning disorders such as ADHD or dyslexia, and then repeated exposure to aggravating environments after the injury.
Why female?
We don't know. It's just something that they found in the research that they've done so far for post-concussion syndrome. There's not a lot of research on post-concussion syndrome. They're just kind of beginning it, but unfortunately, there's probably a hormonal correlation to it.
One of the, like I said, we're not exactly sure, but one of the reasons could be that females have a less of a strong neck. They have less musculature in the neck, and the neck is actually a very important protective mechanism in sustaining one of those whiplash injuries. So that could be a potential reason why we're still waiting for the research on that one.
Yeah. So post-concussion syndrome, like I said, it's about a recovery that's longer than a month, but can last several months, even years, we've seen. It's a term, like I said, for a recovery that's an unusually long period of time. It is multifactorial, and what kind of contributes it is not quite 100% clear of what's involved with why some people have prolonged recoveries. The most common symptoms are kind of those same symptoms that people have right after a concussion, regardless of duration. So that'd be headaches, dizziness, feeling tired, cognitive deficits, sleep disturbances. A lot of times these patients did not properly manage their concussion right after, so they continued working, they continued in school, kind of pushed through their symptoms. They might have not even realized they had a concussion, and then they're 2 months out and are still having symptoms. Just because they didn't kind of rest enough right after. So treatment for post-concussion syndrome is very individually based. It's based on what they do for work, if it's a child or an adult, what their most dominant symptoms are that are bothering them. Rest is still the most effective therapy that we recommend. And then obviously avoiding activities or symptoms that exacerbate, activities or situations that exacerbate your symptoms. And then depending on the severity and duration of symptoms, we would start implementing therapy such as physical therapy, cognitive therapy, or occupational therapy, which Kristen and Caitlin will go into later. So let's just do a little fact check here. So a concussion requires loss of consciousness. This is a myth. Like I said, it only occurs about 10% of the time, so it definitely should not be used as an indicator in deciding if somebody's been concussed or not. So adults typically recover faster than children. This is a fact. Children have brains that are still developing. They have less myelin, which is a coating on nerve cells that allow them to communicate more efficiently. So when you have less of that, they're more vulnerable to damage when getting hit. Also, kids' heads are disproportionately larger than adults compared to their neck and body size, kind of what Kristen was just talking about. So the exercise and the weight, along with weaker necks, leads to greater forces sustained when they are hit. And it isn't until about age 14 that a child's head is about 90% of the adult's head, making them kind of equal to adults. So a blower hit needs to be directly to the head. Like I said before, this is a myth. You can have a whiplash injury, which would be a jolt to the body, and not actually getting hit in the head, but the skull still rapidly changes in direction and sustains a linear or rotational force to the brain. After sustaining a concussion, you should stay awake or be awoken every 2 hours. This is not true. Common symptoms after a concussion are drowsiness and fatigue. That's probably one of the most popular or most common ones. So it's important for the patient to get good quality rest and sleep at night to allow for brain healing. But I do want to note this is as long as all those red flag symptoms are not occurring. If that's occurring, you want to go to the ER and not go home to go to bed. And then lastly, helmets will prevent concussions, and this is a myth. There's not any equipment that can eliminate risk for concussions. Helmets and mouth guards can lower the risk for bruising and skull fractures by about 60 to 70%. They can also give you more information about the impact, about if there were cracks in the helmet or kind of where they were hit, if there's denting or anything. One study found that football helmets can provide protection from the linear impacts, but not as helpful for rotational, which is the most common in football, for concussion sustained in football. So, and then another study I found showed football helmets reduce the risk of a brain injury by about 20%. And this is mostly because helmets can't stop the brain moving from within the skull because it is floating in cerebral spinal fluid, so helmets don't prevent that. Any other questions? Yes.
But since you're doing myths and facts, I had one of my children fell and hit their head on pavement once, and someone said, "Oh well, she cried right away, so she probably doesn't have a concussion." Would that be a myth?
Yes.
Yeah.
They're probably in pain, so
Yeah.
the normal reaction is to cry.
Yeah.
Yeah, so I would say that's definitely a myth. You hear some interesting things. Yep.
My daughter took a soccer ball in the spleen area,
Yep.
and the emergency room suggested that it was actually a concussion to the spleen. Is that something?
I would say, I mean, it's a different organ, so not what we see, but I would say like bruising to the spleen or some sort of, obviously there's not brain cells in the spleen, but some sort of damage to the tissue that's in the spleen.
So it's the same forces.
Yeah. That can cause an injury to tissue in the spleen, yeah.
I apologize for asking another history question, but double concussions. So I was in a car accident, hit, and then immediately hit a second time. Does that count as 2 concussions?
I would say yes.
In the same amount, at the same time, like the force, like you hit your head on the steering wheel and then hit it in the back, or were you hit on 2 separate occasions?
Like 3 seconds apart?
I would say that's probably one.
It's the
I'd say
same,
that
because
one.
the forces haven't stopped at that point, the forces within the
So
brain.
2 cars though. One car, second car hits the first one, hits me again. And both of those head hit backrest.
Were you still in movement when the second car hit
Yeah,
you?
and then the seat broke.
Yeah. I would say that's one.
Yeah.
I think because, like Caitlin was saying, the brain was probably still in movement, in motion in those 3 seconds
Right.
before it sustained another injury. And also, some people get in a car accident and they're fine. They don't have a concussion. So it would be hard for us to tell if you didn't develop symptoms in the next few days.
I was not one of the ones who was fine.
And that kind of is a good segue into my part. Again, I'm Kristen. I'm also one of the nurse practitioners at the Concussion Center. And I'm going to talk a little bit about what our team does at the Concussion Center and some of the factors that make us such an effective concussion center. Before I get to that, I wanted to see how many people in our audience today have had a concussion or know someone who has a concussion. So we have almost everyone in here. And so they're definitely becoming a lot more prevalent in the community. We're getting better at recognizing them, and parents, coaches, school nurses are getting a lot better at actually getting them treated. So either sending them to the primary care provider's office, going to the emergency room, or sending them to a concussion clinic like ours. We only opened about 1.5 years ago. So I'm interested to see when your family members or yourselves got concussions, where were you guys treated?
I took my kids to the primary care, but that was the only, honestly, it didn't occur to me to call 911.
Everyone else, kind of primary care office?
So I spent 5 months under the care of Chiropro in Acton.
Good. And they're all great options too. You really can't go wrong whenever you're seeking treatment. A lot of providers are, like I said, getting a lot more knowledgeable about concussion management and recovery. And we're a good clinic for treating concussions as well as post-concussion symptoms, which is what Alan talked about and what we're going to talk about further, is what happens when the concussion lasts longer than 10 to 12 days. So that's usually when you might need further treatment, and that's one thing that we're really good at and we specialize in. Number one, because we're lucky enough to have Dr. Cantu as one of our neurologists. He's the neurologist that our concussion clinic is named after. He's one of the country's leading experts on concussions and concussion management, and he's actively involved in creating the most current concussion guidelines. He's always traveling to Europe, and he's always out of the country at some time, actively developing our most recent concussion guidelines. He has personally trained all of our nurse practitioners, and we work with him very closely. He's always available for us to consult with for any treatment or concussion management questions. He has dedicated the majority of his career to studying concussions and researching concussions, and there really is very few things that he has not seen throughout his career. So we're very lucky to have him as a resource in our community. So another reason that makes our team a very effective concussion center is that we utilize a team approach. So our concussion center and all of our neurologists and providers, we're located in the same building as our rehab therapies of physical therapy, occupational therapy, which is therapy for the eyes, which Caitlin will talk about sooner, as well as cognitive therapy, which Caitlin will also touch on, but that's basically the mental therapy for the fogginess, the can't think straight, the trouble making decisions, trouble getting back to work. So we're all located in the same building, so this provides for a very unique multidisciplinary approach. So we're all in constant contact with the therapist. We're very up to date on the patient's progress. We're very up to date about any life stressors that might be going on or any changes in their treatment. We're up to date right away. We also practice very individualized treatment. Every concussion is different, and every patient is different. So there's a saying that once you've seen one brain injury, you've seen one brain injury. That's how it is. Every patient responds differently to our treatments, and every patient's symptoms are different. So there really is no one plan fits all approach. So one of the things that we specialize in is really being able to individualize the treatment plan to the patient based on their specific symptoms. And the third thing that we offer to our community is things like we're doing tonight, education and support. That's one of our most important goals, is to kind of spread the word about concussions and make more people aware of when they or a family member or a loved one might have a concussion, so that people can get help and not have these symptoms for months and months. Yes?
Is there a relationship between concussions and Alzheimer's? Are you seeing that?
So I'm going to get into that a little bit later about development of neurodegenerative diseases and concussions.
So we're going to say we'll hold off on that one. So we'll be able to explain it better with some slides. Stay tuned. Good question. So just quickly about our team, the Concussion Center, we currently have 2 neurologists, and we're soon to be adding 1 more in July, who will be specifically a pediatric neurologist. There's 3 nurse practitioners who are all here tonight. And as well, starting in July, we're going to have a team of psychologists and neuropsychologists to better treat some of the psychological effects of having a concussion, especially very long term. We also have a fantastic rehabilitation team. This includes 14 physical therapists that specialize in a wide variety of physical therapies specific for concussion, which I'll get to later on in the presentation. We have 5 occupational therapists, and we have 3 speech-language pathologists. Some of these therapists further specialize in solely pediatrics. So we really are, we're all family nurse practitioners, and we say womb to tomb. So we really treat the whole lifespan. I think my youngest patient has been 11, and my oldest patient has been 93. What about you guys?
Pretty close.
Pretty close?
Yeah.
Yeah, 8 to 80.
Mm-hmm. So and a lot of our therapists are trained throughout the lifespan as well, which makes us also unique.
Can you just explain the difference between a neurologist and a neuropsychologist?
Sure, good question. So a neurologist is a medical doctor who works solely with the brain, the medical part of the brain. A neuropsychologist is not a medical doctor. They're a psychologist who specializes in working with patients with brain disorders. I would say. They also, a neuropsychologist would be someone that you would go to if you thought that you might be developing Alzheimer's or dementia. You maybe would go see them if you thought you had ADD or ADHD. They're trained in specific testing to rule out or rule in certain diagnoses based on personality, symptoms, and how you score on specific testing. Cognitive testing. Mm-hmm.
We are hearing, we're Human Services and Safety, and we're hearing an increase in falls for the elderly. Now, are you seeing a commensurate increase in the number of elders seeking your services?
We haven't done any studies yet that we've tracked our patients in that way.
You mean from falls specifically? Yeah.
We do quite a bit, but I don't think it's greatly increased in the past few months. Mm-hmm. Not that we've been seeing.
Given that so many folks are, God forbid, living so long, there should be, if there is a relationship.
Mm-hmm. I would say a majority of the older adults that I treat, it is for falls. Majority for falls and some motor vehicle accidents as well.
At least if a patient presents to the hospital, are they usually admitted for this? Or
if they present to the emergency room?
Yeah.
Honestly, they're usually not. Usually brain imaging really isn't even done. We really don't want to do brain imaging in the emergency room if they don't have to, because they would give you a head CT, which is also called a CAT scan, and in order to get that, you actually are exposed to some radiation. So we really don't want to do that unless we absolutely have to. There's very specific criteria that you would have to present with for them to give you a scan of the brain. Some of those include a very traumatic mechanism of injury, meaning a very severe car accident, or some of the red flags we talked about where you did have the liquid leaking out of your ears, or you lost vision, or any facial drooping. There's very pretty specific criteria if they're going to expose you to radiation. Usually concussions, they don't even show up on imaging. You could have a very severe concussion, have a very normal brain MRI. So they don't really tell us that much. They're more to rule out anything more serious. And if anything more serious was going on, you would most likely present with some of those red flag symptoms. So usually they're assessed. The providers in the emergency room will give you a good neurological exam, which I'm going to talk about. And usually they will determine that you do have a concussion, and they'll usually give you a note to be out of work for a day or two and discharge you with instructions to rest and to follow up with your primary care provider in a few days. So some of the services that that our team does at the Concussion Center, we treat concussions, we treat post-concussion syndrome, and we treat symptoms of chronic traumatic encephalopathy, which is what Caitlin is going to talk about. That's usually something that a lot of the football players get after repeated hits. Usually nothing that a regular person in the community worries about unless they've had sustained a lot of hits in their lifetime. We also do baseline testing. This is baseline testing for healthy athletes, and the goal is to do it before the season starts. So before someone gets a concussion, we basically want to get a baseline of how their brain is working, and it provides a snapshot of the healthy brain function for comparison should an injury occur. So ideally, it's done at the beginning of a sports season. It gives us objective data to compare pre and post concussions, so we know when someone's ready to go back. All testing is performed by a certified, licensed physical and occupational therapist, and it includes an impact baseline test, balance error scoring system, and a King-Devitt concussion screening test, which I'm going to explain for you. So the first thing we do is the King-Devitt, which is eye tracking. So when you get a concussion, sometimes some of the cranial nerves that control eye movements can be a little bit impaired. So that might be causing some of the headaches and fogginess that you're experiencing if the eyes are not working well together. So we want to assess that. What we're looking for is the speed of the eyes and the smoothness of the eyes. And the way that we track that is by having, it's too small to see, but there's numbers on those cards, and we have people read the cards and have their eyes track. And the way we assess the speedness and the smoothness of eye movements is how long it takes you to read the card and how many errors you might make. We also assess balance, so we usually do balance on a hard surface, such as a floor, or as well as a foam surface, to see if there's any balance deficits. That's really important, especially in our with our older patients, because we want to make sure that they do not sustain another fall. So if there are any balance deficits, we want to give them skills and coping mechanisms and get them into therapy right away so we can prevent another fall. We also do impact baseline testing, which is a computerized test, takes about 25 minutes, and it tests different components that are generally affected by a concussion, such as visual motor speed, verbal memory, visual memory, and reaction time. And the way we do this is you use the mouse and the keyboard to do a series of tests. So who do we treat? So we treat a lot of athletes participating in a wide variety of sports. We treat a lot of falls. This could be falling down the stairs, slipping on ice, slipping over a dog or a cat, slipping on a loose rug that wasn't put down. We do a lot of motor vehicle accidents, and we also do work-related injuries. That's primarily our patient population. So what do we do at our first visit? When you come in to see us, we really want to get to know you a little bit better before we start making a plan. So what we'll do first is do a comprehensive patient history. We'll really get to know you and your concussions very well. Then we'll do a medical examination. So first we'll talk about the most recent injury in great detail. We want to know the date of the injury, so we know how long you've been having symptoms and kind of, your progression. We want to know any immediate symptoms following the injury as well as current symptoms. So this includes any loss of consciousness, any amnesia, light or noise sensitivity, any nausea or vomiting. We also want to know what medical follow-up and diagnosis that you had. Some people, we see them a few months after their concussion. So we want to know what they've done before they've come and seen us. So this includes, did you go to the emergency room? Did you have an MRI or a CAT scan done? Did you go to your primary care provider? And who diagnosed this as a concussion and when? We also want to know triggers that may increase symptoms. So this could be, like Ellen was referring to, school or work, exercise, sleep, and any type of screens. Those are usually the top ones that patients have really a hard time with when they have a concussion. Next, we want to talk about every concussion that you've ever had. Some patients have had up to 14, if not more, I would say. And this really goes into the whole history of what we need to know to be able to best treat the patient. So we want to know the total number of concussions sustained over a lifetime, and then pretty much for each concussion, the same things that we talked about. Especially we want to know the duration of symptoms, so how long symptoms lasted until you felt 100% back to yourself. This gives us a good idea of the intensity of the concussion. Usually the longer symptoms last, if you were receiving appropriate treatment, that usually gives us a good idea of how severe the concussion might have been. And then we want to know your current symptoms. This is the symptom checklist that Ellen was referring to. This was created by Dr. Cantu, and it's about 26 symptoms that you could possibly have following concussion. And it's scored by the number of symptoms you had out of the 26 and the intensity of the concussion symptoms, ranging from 0 to 6, 6 being extremely severe. And this helps us to track the patient's progress over time, so we can see if they're getting better, if they're getting worse, and kind of how they're a little bit more of an objective measure of how they're doing. We'll then talk about the patient's medical history and their family history. This is specifically because there are some conditions that may affect concussion recovery. These include any type of depression or anxiety or panic attacks, a previous history of migraine headaches, any type of ADD or ADHD, dyslexia or other learning disability, a seizure disorder, or other psychiatric disorders. Research shows us that having a family history or a personal history of any of these conditions could put you at risk for having a longer concussion recovery. So it just gives us a little more information of why you could be having a longer recovery. And then of course we'll ask about any medications and allergies. Then we'll do our exam. So it's a comprehensive neurological exam, and this starts with cognitive testing, which is kind of, we want to see, it's kind of like the internet. We want to see how fast the brain can work and for how long it can work like that before it gets a little bit jammed up. So we'll do some easy, simple mental tests. We'll have the patient, memorize 5 words and repeat them back to us. We'll have them say 6 numbers backwards, and we'll have them do a little bit of mental math. Things that can actually be pretty hard for people who don't even have a concussion. Some people just can't do mental math, so that is something that we take into consideration. We'll also do some tests. We'll test the eyes. We want to see, again, how smooth the eyes are working and how fast they're working. We also want to see if there's any blurry vision or any blind spots in the vision that we would want to address. We also do balance testing. Again, we want to know the extent of the balance problems and to know if we need to intervene sooner so that we can prevent any additional falls while the patient is still recovering. And we'll also assess the head and the neck. As we discussed, the neck it often takes a lot of the brunt in a concussion due to the whiplash. So we want to test, if the neck or any of the muscles surrounding the neck are tender or painful, or if we feel any spasming, as well as the range of motion of the neck. Can you move the neck in all directions without pain? So then we get to the good part, treatment. What are we going to do now that you have a concussion? So this is really the meat and bones of what we do. Number 1 is rest, and then if we have to, we'll do some referrals to some rehab therapies or some other services. And then we'll talk about either a return to work, return to school, or return to play, depending on the patient. So number 1 is rest, rest, rest. This is limit cognitive stimulation. Anything that makes the brain concentrate is basically a cognitive stimulation. This includes work activities, any type of school activities. Driving is actually very stimulating to people. You have to think, the lights, people are moving. That's actually one thing that people don't realize, how much you really have to use your brain when you're driving. We also would want you to avoid any environments with noise, lights, or many people. This would include going to the grocery store, going to the movie theater, going to a shopping mall. Similarly, there's lights, there's noise, there's people everywhere that the eyes have to focus on. Very stimulating to the brain. And then again, we want you to greatly limit any electronic media, which can be very hard for people of all ages, but also a lot of our young kids have a hard time with this. And then limit any physical stimulation. So any vigorous activity, including bending and lifting. So this is even things such as light weightlifting, no sports, and avoid activities that can lead to further injury. This can include skiing, ice skating, mountain biking, but also things for our older population. I wouldn't want someone who has a concussion to be the one on the stool changing the light bulb. Okay, especially people who live alone. This is a common concern for a lot of them, and they have to do everything themselves. So when I'm telling them that they can't, reach up overhead while standing on a step stool because I'm worried about dizziness or balance, that can be concerning for them. But our number 1 priority is to make sure that they do not sustain another head injury and that they don't fall. So we have some good conversations about, turning on lights and not walking through the house blindly, at turning on lights so you don't trip over anything, not getting up on a step stool to put something in the counter or to change a light bulb, things like that. And we talk about, for a short period of time, you might have to have another family member come over and help you do some of these things. Also, if someone does have a cane or any type of assistive walking device, we highly encourage them to use it, especially during this time, because we cannot risk them getting another head injury. Depending on their symptoms, they might need a referral to some of the therapies. Caitlin's going to talk a little bit more about this. So one of these is physical therapy, and there's actually, all of these are types of physical therapy specifically for concussion treatment. And Caitlin will get a little bit more into detail about them, and I will as well later in the presentation. Also, we might refer you to occupational therapy, which again is therapy for the eyes, or cognitive therapy. We also refer someone to the eye doctor, so optometry or ophthalmology, if we thought they had any structural deficits in the eye that we would want to get further assessed. We would refer them to ear, nose, and throat, or ENT, if someone had persistent ringing in the ears that just wasn't going away, and we wanted them to have a little bit more of a further assessment, again, to see if there's any structural damage to the ear. We already talked about neuropsychology and psychiatrists. Some people have mood disorders that pre-existed the concussion that can be made worse by the concussion, or someone who, especially if they have a longer recovery, can develop a mood disorder. And so we would send them for help with management and treatment of that. We'd also send someone to an endocrinologist if we suspect they had a hormonal imbalance that possibly could be causing some of their symptoms, such as the fatigue, dizziness, things like that. And then we also refer to acupuncture, meditation, biofeedback, and yoga. These are specifically to lessen the intensity and frequency of any concussion symptoms, specifically headaches, and also to reduce kind of overall stress, stress management. So this is one of our therapies that's unique to the Concussion Center. It's called MyoWorks. We're one of the only people in the area who has this. Like we discussed, the neck plays an important role in protecting the brain from head injury. The brain injuries may affect muscles in the neck and upper back, again, from kind of stopping the blow. The neck is strong and it's able to stop that whiplash. But because of that, the neck may have decreased blood flow to the brain and may affect the communication between the cranial nerves. So as Ellen was talking about, the nerves communicate with each other, and sometimes with decreased blood flow, that communication can be interrupted. And this is what can produce concussion symptoms of the fogginess, the headaches, the irritability, things like that. So what MyoWorks is, it's an electrical stimulation device that targets specific neck muscles to decrease pressure on nerves in the brain, increase blood flow, and return the brain to its normal condition. So we'll put different electrodes on different parts of the neck and upper back, and it helps to decrease the spasming and it increases some blood flow in that area. We also have the Vasper. We're one of the only people in this area, again, who has this machine. It's utilized by a lot of professional, or not a lot, but some professional supports teams. And as of last year, NASA was experimenting with it as well. So it blends two approaches of cold therapy and blood flow restriction. What it is that's a picture of one of our therapists on the bike. It's basically a stationary bike where a patient's stomach and limbs are with a blood pressure cuff on them that compresses, and also the bike is cold. It's flooded with cold water. So we use a mechanism of cooling and compression to basically keep the heart rate low. And basically the idea is that some patients cannot be physically active after their concussion. Their heart rate increases and all of a sudden their concussion symptoms come back. So the goal of Vasper is to keep the heart rate low and to still exercise at a high level without producing any concussion symptoms. And the goal is that the people will be able to get physical activity and to be able to exercise at a high level without triggering any concussion symptoms. And this would be good so that they can still get the natural benefits of physical activity, including all the endorphins that can help with some of those persisting symptoms of feeling slowed down, feeling out of it, the confusion, and basically get all the good natural benefits of physical activity without getting the concussion symptoms. And then, depending on the patient, we'll do return to work. It's always a gradual re-entry. We never send someone back full-time unless they're 100% ready to go and they're having no symptoms. For example, we might send someone back for half days for a week and then slowly increase to full days. And we also are able to give them some work accommodations depending on symptoms, and there's some listed of what we would do for them. Similarly, return to school, we want it to be gradual, and we work with our cognitive therapist of recommendations for students based on how they did on testing. And again, just here are some quick examples of what we would do for students for some of their symptoms. A lot of it is allow extra time on homework tests and quizzes, being able to wear a hat, sunglasses, and earplugs in school to lessen this, the light and noise sensitivity, avoiding gym, choir, anything that could exacerbate symptoms. And then we have the whole return to play protocol. In Massachusetts, there is a law that a concussed athlete does not return to contact sports until cleared by a medical provider or certified athletic trainer. So that is a law in Massachusetts, and it's a graduated re-entry plan. And all the key players are involved, but the coach and the athlete do not get a say. This is to prevent athletes from going back too soon and not feeling pressured to go in too soon. And this is just a quick example of our return to play protocol, and as with everything, it's very slow. So you'll start at no activity level, and then depending on how your symptoms go and as you improve, you can gradually increase your physical activity. And to be officially cleared from a concussion, you have to have no symptoms at rest and with physical activity. So this would mean, you are in work full time and you still have no symptoms. You also wouldn't be able to be on any medications that may be masking concussion symptoms, such as Tylenol or ibuprofen. Those could be masking headaches. So like I said, you have to be back to work full-time, doing your regular work responsibilities with no symptoms. Would also have you have a normal neurological exam, so all your eye testing and balance would be normal. If you had a previous baseline test, we would give you another impact test and make sure you did better or the same as you did previously. And for our athletes, we would have them do a graduated physical activity with some of our therapists and just have no concussion symptoms. So it's a very thorough process, and we want to make sure we're safely returning everyone to their normal activities, and so we can 100% say that they are cleared from their concussion.
All right.
I had a stroke in September, and I am watching all your slides and feeling anyhow that there's some similarity between a stroke and a concussion. Now, it seems as though you all have a very tight protocol, but I'm interested in whether you see people who have had strokes and misidentify what they have, or how do you know the difference, in a sense? Because I believe that a lot of the symptoms are the same.
Well, I had one patient that was essentially misdiagnosed and with a concussion, which actually a stroke. So we can definitively diagnose that on an MRI because we're going to see issues with the brain tissue. It doesn't happen very often, to be honest. It's not. That was probably a very rare case. But that's how we can definitively diagnose, because concussions will not, no instance of concussions will be identifiable on an MRI or a CAT scan. There's essentially no way to diagnose a concussion other than talking with the patient, discussing their myriad of symptoms. There's always an impact. So it doesn't necessarily, like we had mentioned, there doesn't have to be an impact to the head, but a whiplash injury. There has to be some force of injury or mechanism of injury to occur for a concussion to occur. It doesn't just happen randomly. Whereas, of course, as you know, a stroke can happen randomly. Obviously, there's insults within the brain that occur, but you could be sitting there and have a stroke. You cannot be sitting there and sustain a concussion without an injury.
And I asked earlier about a relationship between Alzheimer's, dementia, and concussions. Now, I know this all the stuff with the athletes and football players, and they get that CTE thing, but just sort of normal people.
Yes, so I am getting to that.
Okay.
Yep, it's going to be just right at the end of the presentation.
Okay.
Will be the last slide. So just to give a brief overview of why you need various rehabilitative therapies with post-concussion syndrome, because we've sort of talked about our comprehensive team and multidisciplinary team, but why do you need them? Well, because various insults can occur through injury to the cranial nerves. So you have nerves which connect from your brain to various areas, but one in particular is your eyes. You have, as well as you have 6 ocular muscles. After an insult to the head, these muscles as well as the cranial nerves can basically just not connect properly and not talk properly to the eyes and lead to symptoms. Some of these symptoms are difficulty when focusing from near to far, so you have trouble accommodating from near to far, issues with reading or focusing on the computer. That's why oftentimes people will stay away from using the computer, because they tend to be tremendously symptomatic when doing so early on. They're very light sensitive, especially when driving or again using any type of electronic. Blurred vision or headaches can actually be caused by some ocular motor deficit. So our occupational therapists are typically dealing just with ocular therapy. They provide various exercises as well as accommodative measures to help minimize the patient's symptoms and also help correct them, because through various exercises you can actually help correct and improve some of your symptoms. The second is speech pathology. This is cognitive therapy. So it's dealing purely with cognition, memory, recall, attention, concentration. We have 4 adult speech language pathologists and 2 PD speech language pathologists. And essentially what you do is you visit with the speech pathologist. She runs you through a series of tests. Based off your testing, your results of your testing, she's able to develop a comprehensive plan to either get you to return to your prior functioning, whether that be school, work, or just your day-to-day functioning, because oftentimes we see people that just have trouble functioning day-to-day, remembering tasks, activities, grocery lists, things of that nature. So they can find that to be tremendously helpful. And lastly, physical therapy. Kristen had touched upon this earlier, that we have a number of various therapies that we can provide through a physical therapist. One is vestibular therapy. So your vestibular system is a very complex system that deals with your brain, your eyes, and as well as your inner ears, and helps regulate motion, equilibrium, and spatial orientation. Oftentimes people sustain a head injury, feel tremendously dizzy, like the room will spin around them, or they'll feel like they're on a boat. That's typically the vestibular system. And it's one of the areas that we can correct with the help of a physical therapist and improve functioning. Another is cervicogenic therapy. That's dealing predominantly with the neck. Oftentimes neck symptoms such as spasms, typically after motor vehicle accidents, you can have a tremendous amount of spasm, can generally radiate up forward into the head and create what we call cervicogenic headaches. So our physical therapist can help by stretching, strengthening the cervical spine, massage, which our patients always love, and can tremendously help the headaches that are occurring on a regular basis. We also have cranial sacral therapy. This is what we consider, it's not very well studied in the world of concussions, but it's fairly understood with headaches. And essentially it's a nice light massage of the head. And we actually have sutures within our brain, within our skull. The sutures are actually not fused, and they can be slightly manipulated through massage, and the thought is that it helps alleviate pressure and alleviate headaches. Some of our patients swear by it. They absolutely love the treatment. And some various things that we also provide that is specific to our clinic is a return to play protocol, where we help run our athletes through, or really anyone, but mostly athletes, through a 45-minute agility, cardiovascular and endurance exercise, and it gives them the official clearance to go back to sports. Oftentimes our return to play protocols are sort of self-reported, meaning that the athlete has to report if they're having symptoms while exercising, and oftentimes it goes unreported because they just want to go back to sports, but that puts them at a tremendously greater risk of sustaining another concussion. So being with a physical therapist, you're just with another expert who can kind of identify the symptoms and say maybe it's not time to go back just yet. And lastly, many patients with post-concussion syndrome have a very difficult time returning to their exercise, which they had participated in prior. So the exercise protocol, we sort of develop a home exercise program for you. You check in with the therapist once every 3 to 4 weeks, so it's not a regular physical therapy program, but it helps you start integrating exercise back into your life, because there's a tremendous amount of research into how exercise improves cognition, physical functioning, and also improves emotional symptoms as well. So some just recent research that I was going to touch upon. What I find interesting about working in concussions is how frequently their recommendations, or how they're going to start changing the whole paradigm of concussion treatment. 5 years ago, or even to this day, sometimes people will meet with providers and they'll be told to rest for 24 to 48 hours, not return to any activity before they're symptom-free for 24 to 48 hours. So 70 to 90% of our patients, that's going to be just fine because they're going to recover within that time frame. But there's a lot of patients that go on to develop post-concussion syndrome that 10 to 20%. So some recent research has been brought in to sort of try to identify what would be a reasonable recommendation to resume physical activity. Because the current recommendations, oftentimes we tell patients will just put themselves in their room, shut the lights off, and they don't want to come out till they're feeling better. Well, when that becomes greater than 24 to 48 hours, that can lead to fatigue, physical deconditioning, anxiety, as well as depression. And oftentimes these patients present to our clinic that way, and they've been sort of resting for the past 6 months. And we can't possibly expect them to be returning functioning as they normally would when they really haven't been able to participate in any kind of activity. So this recent research that I was looking at that just was presented about a couple months ago, it did look at children. So It was looking at ages 5 to 9 over a 2-year span, recruited from 9 pediatric emergency departments in Canada. And the injury had to occur within 48 hours, and essentially they had to meet specific concussion diagnostic criteria. And each patient that was evaluated and was included into the study was followed up at 7 to 28 days, in 28 days. And essentially when they followed up with these particular patients, they would ask them what current level of activity are they participating in. So the researchers did not intervene or provide any recommendations. They sort of just let the patient go do as they please. And they categorize it between anywhere between no activity to just return to competition. Obviously with the various levels of activity in between. And it was very interesting because it was found at day 7, over 1,600 participants that engaged in physical activity. So all the way from moderate activity or light activity, all the way to competitive sports. 31.3% were symptom-free and 48% had at least 3 post-concussive symptoms. And of those reporting no physical activity, almost 80% had at least 3 post-concussive symptoms. So it's that is very significant. And then at the 28-day mark, early physical activity was associated with a lower post-concussion syndrome symptom risk than those with no physical activity. And the percentiles were 24.6% who had participated in physical activity versus 43.5%. So it definitely evened out towards the 28-day mark. So the conclusion from that research, it's not necessarily applicable into the adult population, although if you, early on when Ellen was mentioning that children are actually at greater risk of developing post-concussion syndrome, I do think it's fairly applicable, meaning that more likely than not, we probably should be getting our adults back into some type of physical activity earlier than later. The sort of limitations of this particular research is that we need to find out the optimal quality and timing of the exercise, because as you can see, it was a large variation of light exercise and return to competitive sports, which we would never recommend someone do shortly after sustaining a concussion, unless cleared by a medical professional. But also the timing of the exercise, when you should be engaging in it and what particularly you should be engaging in. And then also researching youth versus the adult population.
I would also think the seriousness of the concussion would have something to do with it as well.
Yep, severity of symptoms. So there were a tremendous amount of limitations to this study, and the researchers did recognize that. But it was just sometimes almost like a catalyst study to identify that, okay, actually the paradigm probably does need to change. So this is the direction that we should go in. And yes, I completely agree with you. So just a quick injury prevention, because oftentimes we get this question in the clinic, how can I prevent myself from sustaining another concussion? Well, as Ellen already mentioned, helmets really don't do much of anything. They prevent severe traumatic brain injuries. Skull fractures, brain bleeds, they're fantastic at doing that, but they are not fantastic at reducing concussions. In fact, they may result in an adverse behavioral change that the athlete becomes a bit more aggressive because they feel more protected with that helmet on, which is really not the case. We always recommend anyone in sports or activities, they play smart. So that can be applied to sort of any kind of activity. Try not to get too aggressive in whatever it is you're doing. Don't, if it's too risky, the fields are too wet, ground's too wet while walking, it's too icy out, especially in the winter. Just be smart about during the times of physical activity. You can help reduce the concussion. And then strengthening your cervical neck. It's actually, some research has shown that just a few days a week, 10 to 15 minutes of cervical neck strengthening exercises, which can easily be YouTubed online, will help to reduce concussion risk, because the stronger that your neck gets, it's the thing that supports your head, and it will actually reduce the forces that sustain in your brain, because the force will essentially be distributed at a greater level, and you will not sustain as great of a concussion, or maybe even not a concussion. So, lastly, chronic traumatic encephalopathy. So what you were sort of asking about, can concussions lead to neurodegenerative diseases such as Parkinson's, Alzheimer's, things of that nature? Well, once it was thought that actually concussions could lead to Parkinson's and Alzheimer's, and that's kind of what people were thinking that was occurring. But early on, so I guess I just jumped ahead of myself. Early on, chronic traumatic encephalopathy was described as punch-drunk syndrome. it was seen predominantly in professional boxers, because those are the individuals that are just were getting blows to the head constantly. But it was later published in the Medical Journal of Neurosurgery by Dr. Bennett Amalu in 2005, and this was he was the character, not the character, but Will Smith played him in the movie Concussions. So he was the first to sort of publicize it and actually identified chronic traumatic encephalopathy based off of a autopsy of a Pittsburgh professional or Pittsburgh Steelers football player that had passed away. So essentially what we call CTE, I'll just shorten it, is a progressive degenerative disease caused by repetitive brain trauma. So it's not just caused from one particular concussion. And it's a buildup of abnormal proteins called tau proteins. And essentially the tau proteins will block or will cause plaques that block passages in the brain and will eventually destroy axons, which are nerve cells within the brain that are essential for brain function. So the tau proteins are caused by total brain trauma and not necessarily limited to concussions. Dr. Cantu's one theory now, which it really needs to be researched a little bit more, is that there's subconcussive blows, so blows to the brain that athletes are sustaining over, upwards of 1,000 times within one season. That does not leave them symptomatic, but the brain continuously impacts the skull at a minor level, and can eventually lead to development of the tau proteins due to basically traumatic and chronic inflammation of the brain. So what was interesting is one of his colleagues, Dr. Ann McKee, who works at BU in the brain bank, which is the brain bank is when every time you're hearing of these particular professional athletes that either die from a suicide or most recently Aaron Hernandez, when you hear them donating their brain, they're actually donating their brain to Dr. Ann McKee, who is a very close colleague of Dr. Cantu. And essentially what she's doing is she's looking at their brain, looking at slices of the brain and seeing if there's any presence of tau protein. The 95 NFL athletes that she has looked at, 91 of them have all had evidence of chronic traumatic encephalopathy. So that is what she's hypothesizing is, and most of her research is sort of supporting, is the fact that oftentimes we thought that these patients were developing Parkinson's or Alzheimer's, and they're just not the case. They're developing CTE because tau protein is not found in any other neurodegenerative disease. It is only specific to CTE. So I guess the only other thing that I want to mention was CTE is specific to the medial temporal lobe, which is essential for lots of functions, including memory, impulse control, and you'll oftentimes see depression, aggression, impaired judgment, and then eventually progressive dementia. Current research right now is absolutely essential because you cannot diagnose CTE in the living. There's probable and possible diagnosis of CTE. Dr. Cantu is one of the very few providers in the country that can actually provide that diagnosis, but it can never be definitive until on autopsy. So they're trying to, one, be able to diagnose in the living, two, identify environmental triggers because there may be other factors that lead to CTE, and then also identify genetic predictors because some may be more susceptible to development of CTE than others. Yes?
So would it be accurate to say that the symptoms of Parkinson's, some of them may be like the symptoms of CTE?
That's exactly what it is.
So someone like Muhammad Ali, if he had, I don't know if an autopsy was done on his brain after he died.
That's a great question. I was wondering that driving over here. Do you know if he donated his brain? I don't think he did.
But
to be
he
honest.
was, I think he was widely believed by the public anyway to have Parkinson's disease, but I don't know what his medical people were telling him.
Correct.
But he would have certainly been a sort of a candidate for this.
Absolutely.
Boxer.
Yeah, it's funny, I was thinking about that on the drive over. It would have been very interesting because he presented with early onset, and obviously was presenting with many, probably almost all the criteria that would lead to a probable diagnosis of CTE. So that completes our presentation. Do you have any other questions?
Well, this has been wonderful. And as I've been watching it, I think that there needs to be more attention to these neurological issues across the board. You guys have done a wonderful job on concussions, but you know, there's nothing like this for strokes, at least that I've seen. And I just think that if we could broaden your audience so that it would include, you know, folks that are at home that may have Parkinson's disease, fall. What are the guidelines that we should give families is really what it boils down to. And to make sure that people call 911, because we really do have a good team here and they care a lot. So, I mean, thank you very much. Did anybody else have any questions? We may get some in the mail. Maybe, Laura, if you could.
I'm going to post the video so people can watch it. Yeah.
Great. So thank you.
Thank you.
Thank you.
Thanks for having us.
Thanks for having us. Yes. Good to meet you guys.